I will start this webinar. Okay, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Yeah, thank you for all participants for attending our wonderful webinar today in biomedical instrumentation. So in our webinar today, we have two excellent keynote speakers. First, our keynote speaker is Dr. Rifai from Swinburne University of Technology, Australia. We know him very well because last year we already invited him also as our keynote speaker in our webinar. And he becomes our research collaborator also in the Universitas Airlangga. So for the second speaker is Mrs. Osmalina Rahman, yeah, right? Osma, I don't remember. Yeah, Osmalina Rahma. I'm sorry, I don't remember your full name. Yeah, because our former keynote speaker cannot attend our webinar because he must follow faculty course. This is the requirement of for the government employee, Mr. Alfian. We apologize, cannot attend our webinar today. So the speaker will be replaced by Mrs. Osmalina Rahma, ST and SE, right? Yeah. Okay. We coming into our first session. Before Dr. Rifai give his presentation, I will share about his curriculum vitae first. Okay, let me share Dr. Rifai curriculum vitae. Yes, already appear. Yes, Dr. Rifai got his Bachelor of Electrical Engineering from Krida Wacana Christian University, Krida, Jakarta. Actually, he is Indonesian, but now he is becoming a good, very good researcher and lecturer in Swinburne University of Technology. So we are really proud of him that he can become an excellent researcher in Swinburne University. And he got his PhD in engineering, specializing in biomedical engineering from University of Technology, Sydney, Australia, in 2014. So for the research, his research profile, Dr. Chai explored the brain-body connection through the application in biomedical engineering. Also, he has extensive knowledge and experience in designing biomedical devices and artificial intelligence. So we can see his current research projects are brain-computer interface for smart wheelchair control, driver fatigue and cognitive fatigue classification, freezing of gait in Parkinson's disease detection, emotion classification, rehabilitation using a multimodal system, assistive technology with smart wheelchair, biomedical modeling, artificial intelligence and advanced computational intelligence, and also medical imaging analysis. So this is so many research topic that developed from Dr. Rifai Chai. So without further ado, ladies and gentlemen, let's listen to Dr. Rifai Chai talks with entitled EEG-Based for a brain-computer interface. So Dr. Rifai, I will stop share your curriculum vitae. For Dr. Rifai, the time and screens are yours.
Okay, thank you, Boris. Let me share my screen first. All right, can everybody see the screen?
Yes, visible, Dr. Rifai.
That's good. Yep. First of all, I would like to thank you for the invitation, Ibu Riris, and especially to the Department of Physics, Faculty of Science and Technology, Universitas Airlangga. And I checked the invitation letter actually from HMTB, which is the committee, which is the Himpunan Mahasiswa Teknik Biomedis Universitas Airlangga. So very honored to give a presentation. So the topic is about the BCI, so EEG-based BCI. And as Ibu Riz mentioned, I think this is probably the fourth time I give a presentation. It's around the same topic, but I probably add a few more information for today's. And I've been aware that this is for students, so we'll be slow down when I speak in English. If you have any questions, just let me know. Okay, so you can see here is about the topic is about EEG. EEG we know because this is for the biomedical student and staff as well. So we've been aware EEG have been used in clinical, in hospital. It's a non-invasive that measuring the electrical signal. And also that's for the purpose of the brain-computer interface. I mean, we're measuring the brain signal. You can see there's a two picture here. One of them is actually I'm using the one of the research EEG. So this is not a clinical EEG. This is a research EEG that used for the application of a speller machine. I think one of the slides today I'll talk about how we can use the EEG for speller machine, and I'm testing that application. Then when I think about something and use specific EEG-based BCI, we can use for communications. That's the purpose. And on the right-hand side here, I'm using another brain computer interface type, which is similar as well, which is EEG, but different EEG-based BCI. I'm using a mental task to control a wheelchair. I'll talk about that one as well in today's presentation. Let's go to the next one. Before we going a little bit further, let's introduce BCI first. We talk about companies and startup. You can search around. There can be more of this one. I just last night quickly searched a few companies on the BCI startup. So it means they start to emerge a few companies. For example, the Neuralink. So Neuralink is the founder is Elon Musk. We know Elon Musk is the founder for the Tesla as well. So he have another company that's related to the brain computer interface. Is provide the implant BCI. So implant mean invasive. So they after more invasive rather than EEG, they put the chip inside the brain for the purpose of the BCI applications. And they have the website as well. You can have a look at that. I haven't seen the product yet, but they still put some money doing further research using the implant BCI. The next one you can see is EEG-based, so it's non-invasive, another company that for particular purpose, for seizure. So people with have that seizure, they can use the EEG thing as well. And the third one is BrainScope, is for the point of care diagnosis as well, for the EEG recording. And it's for the traumatic brain injury. So, for example, the patient have the stroke. After stroke, they have traumatic injury, so they can use the EEG to analyze, and even for the rehabilitation later on as well. And the fourth one is Paradromics. That's around the data streaming. So just talking about how you stream the data. And later on, they can even combine with the AI as well, because AI is quite important for particular BCI applications. So today, probably I'll talk about AI as well, but only a little bit. But there's another type of the BCI that we don't need to use AI. So I'm going to introduce that one as well. And the brain gate is quite popular in the research. They use this one for the wheelchair control. And I think this is part of one of the University of America. Oh, sorry. And Neurable is another BCI companies that provide the clinical, even for healthy application as well for the gamings. It's quite popular. You can see later on maybe a lot of gamings company try to use the BCI when it's already on the market. So we can play with the game with the brain computer interface as well. So Milda, another company for diagnosis and also for the the CNS related to the people having the disability as well. And that's the last company, the M.Si Corporation. The same thing that's using the EEG. So most of them that still using the EEG because non-invasive and quite safe. But you can see here, one or two companies, especially like Neuralink, they concentrate on the invasive PCI. Now, in terms of the definition, there's a lot of definition around, even since 2022. The BCI is basically a direct communication interface device provide the brand with a new non-muscular communication and control channel. What it means that so we try to bypass the whole things. For example, if we want to walk, so it means that it always starts from the brain, and then brain have their brain signal even before we want to walk. This intention from the brain, that intention actually we can capture in the BCI. Is called a motor imagery. We just imagine first in the brain, and that's the idea of the BCI. We can capture the prior the action, so motor imagery, and after that, after we try to imagine is that, and also with the other sensor with the eyes as well, and going to the peripheral, the signal will go into the peripheral, the muscle signal, and after that do the action from the pit, and we walk. That's the idea for the whole thing of the muscular communication and control. But the BCI can bypass all of these things, and we just tap into the brain signal, and after that we can use, for example, for the walk. If the person cannot walk, we can use for control wheelchair. Even we can use for the robotic limbs like exoskeleton to walk as well. So there's a lot of benefit using the BCI. Probably maybe one of the option that when people have the what we call a locked-in syndrome, when they when the brain trap, inside the body, they can't use the feet, they can't use the hand, but the brain still function properly. So it means we can use that brain as a alternative method to control and for communications. You can see there's other kind of the definition as well, but it is around that area. And you can see the idea of the BCI is to measure the intention of the user. Although later on they expand it further, it's not just only intention, we just can monitor the brain activity. And again, it's bypass the normal pathway of the neuromuscular. And in terms of the classification of BCI into different things, it can be invasive. So when I introduce a few companies that's using the invasive, and also non-invasive as well. So invasive mainly we can measure by using the electrical signal. One of them is using the chip inside. They have to put a chip inside the brain and just measure the brain cortex. And ECOG, electrocardiography, is semi-invasive. It's on the higher layer. It's not the cortex, but around that bone area, but still requires surgery. But this is a microelectrode as well, but the location is different. They're measuring the electrical signal, tiny electrical signal, but it's stronger than EEG. So EEG actually is measuring the electrical signal as well, but it is non-invasive. It's just on the scalp. They call it scalp. Just touch to the skin of your head there. And of course, it will be a tinier signal compared to the intracortical recording and ECOG. So I mean, in terms of the signal processing, will be quite different as well, because the invasive one is better quality of the signal, and EEG is in terms of the microvolt, so very tiny if you're talking about the electronic behind. And for today's lecture, I think I introduced a field slide that's talking about different instrumentation we can use for designing the EEG as well. And also we can use the magnetic measurement. One of them is MEG. Streamline actually have the MEG, so we can do research using the MEG as well. So instead of using the electrical signal, we can measure the magnetic signal. So then later on, we can have the image through the magnetic signal as well. Or the third option there for the non-invasive is through the blood flow. Is basically measuring the oxygenation or deoxygenation of the blood. So that's where through the blood flow. So it's a bit different than the other one. So the other one is electrical magnetic. This is the the oxygen consumption in the for the neuron, because the brain neuron, they need oxygen for the activities as well. So we can measure that kind of things. So one of them is called functional near infrared spectroscopy. So it's near infrared, so it's quite safe. And this one is quite portable, and it's pretty much similar to the EEG. So maybe this is one of the alternative as well if we want to do a real-time brain-computer interface. And the other two is non-invasive imaging, but it's pretty big. You can find this one in a hospital. fMRI, so it's a magnetic resonance imaging or something. This is what we normally in hospital, we use that one for scanning the brain. People having a stroke, traumatic brain injury, they need to use MRI scanning. And Streamline have this MRI machine as well for the research purpose. So we can actually conduct a research using the MRI, MEG, and also EEG. We are about to get the FNIRS as well with collaboration with one of the company, but we haven't got that one at the moment. But we plan on funding to get the FNIRS. It's quite interesting research that doing the FNIRS as well. And PET, we don't have it normally in the hospital. PET require, I believe it require the radioisotope injections. So it's a bit different measurement, but they measure the blood flow as well. But in terms of the research, you can see still the EEG is the highest method that have been used in the research so far compared to other methods. So that's why in today's topic, I present about the EEG for the research. In fact, most of my research is related with the EEG applications. So this is in terms of the temporal resolution and the spatial resolution. Okay, so the temporal resolution is how fast we can get the data, and also spatial, it means that how much data in terms of the spatial. And you can see, of course, the micro electron will be the highest. Actually, the lowest in terms of spatial. I mean, because we penetrate directly to the cortex. I mean, we can get very precise measurement in terms of the spatial, and also the temporal as well. And it's measured electrical. It means it's pretty fast, and compared to the EEG and other methods as well. Okay. And in terms of publication, get the update. This year as well, but 2021 haven't finished. You can see it's growing very rapidly, even from 1990s when the computer grow in 1990s, when they have the Microsoft, we have the IBM growth, when they have the digital data. Until now, it's from below 10. Now it's around that 900 for last year publication. So you can see a lot of publication around brain-computer interface. Now we talk about the existing BCI using the EEG method. One of them, we call it selective attentions. So selective attention, that means that they require a stimulus. So you mean they need a stimulus and after that we pay attention to that stimulus. And from there, we can get different type of the BCI. One of them is called P300. So a positive peak 300. So after 300 millisecond. Actually, it's not exactly 300. So I think I have one slide talking about this one, and we can get into that one in a minute. And the next one is a steady state evoked potential, SSVP. Still use a stimulus. For example, we use the LED blinking on the certain frequency, different frequency, we can pick it up in the brain as well. And I have one research there. I think I have one paper as well that's using the SSVP for the purpose of the wheelchair control. Okay, the next one is about the spontaneous signal. So instead of, we need to pay attention for certain stimulus. This is straight away from the brain. We don't need the stimulus. It's spontaneous from the brain. We just imagine those signal, and we can use that one. We can tap into that one for the BCI as well. One of them they call a slow cortical potential, or SCP. So you can see the name is slow cortical potential is pretty slow, and these days they don't use this one anymore. Probably maybe can use for the rehabilitation. But in the previous day, this is the beginning of the BCI. They introduced this one. They found out that we can train a brain signal to activate a BCI, but the training is require weeks and months to to get those kind of signal, because we understand that brain plasticity, brain is is complex, but it's also is easier to adapt to certain signal or conditions. That's how they tap into the slow cortical potential, and they use that one. They have to do a lot of training in order to get that particular control signal, and they use that one to the BCI control. Because it's pretty slow, it maybe take even months as well. It's not everybody can get into this slow cortical potential. That's why in the BCI community now is try to avoid using that signal. But the second one is quite popular. In fact, I think most of the research in the publication, they concentrate a lot on this second one, sensory motor rhythm, SMR, or what they call motor imagery, or what the features they call it event. So it's typo there. So event related desynchronization, synchronization, ERD, ERS, and they concentrate on what we call alpha range. But alpha range on this area they call mu rhythm is around 8 to 13 hertz if we convert it into a frequency. Because most of the EEG community, or even the clinical, they concentrate a lot on the frequency wise rather than a time domain. So they found out that before we doing action, so that's why in the beginning I introduced example of how we use the brain to work. Is before even we can work, we can instruct the foot to work. Actually, it started from the brain, and it's called a motor imagery. We need to imagine, so that brain imagination is started in the brain, and we can tap that one based on the imagery only for the BCI purpose. So the features called ERD in ERS, they concentrate on the 8 to 13 hertz of the mu rhythms. So before I'm talking about a bit further, I just introduce a brain wave. So in a EEG analysis, for example, in a hospital, doctor will measure your brain signal, and after that, they will check your brain waves. So in a EEG perspective, in terms of frequency, they divide it into the delta, beta, delta, theta, alpha, beta. So delta is around 0 to 4 hertz of the range of the frequency. If we're talking about the frequency, so the theta is around 0 to 4. Delta is around 4 to 7. Alpha is around 8 to 13 hertz. So that's why sensory and motor rhythm, they concentrate on the alpha, but they call it a mu rhythm, so around the 8 to 13 hertz. And another one is beta, is after the 13 hertz, around, I think around the 14 around 14 to 30 hertz, and the last one is gamma, is after the 30 or 40 hertz. And the next one is there's another spontaneous signal. So instead of using the motor imagery, we can also using non-motor imagery, sort of different mental tasks. Okay. And next, we're talking about the applications. The application of the BCIs, basically, we can divide it into 3. So we can use that one for what we call an active BCI. So for example, you concentrate on the a mental task, a motor imagery, that's what we call active BCI. Reactive EBCI, we reactive to a certain stimulus, like P300, like SSPP, because we need stimulus, I mean reactive to the certain stimulus that can use for the BCI. And also the third one that introduced for the BCI, now we can use for the monitoring as well. So you can see in terms of the different application, and basically you can divide it into 1, 2, 3, 4 applications can be used for replacing a function, like my research in wheelchair control. So it's one of the BCI for the replacing a function, or can be restoring a lost item. For example, you can use that one to control a neuroprosthesis or robotic limb, something like that. Or it can use for the enhancing. So enhancing is related with most of it related with a passive BCI. For example, is one of my research. So I don't have a picture here for the driver fatigue, or even for the gaming here, we can monitor the brainwave. We just monitor, and then that one can detect the fatigue. During the games, during the driving, we can use that sort of application as well. Or the last one is the improving. It means we can use that one to improve the function of the person, for example, for the rehabilitation. So it means that people having a stroke, people have a spinal cord injury, we can use that one to improve, to rehab the functioning of the limbs as well. Okay. Now we quickly talk about the instrumentation. I'm going to check the time, so we still have time there. So basically for EEG, so we want to design EEG. In fact, we can design. It's quite cheap actually. We can design easily this EEG. So EEG is measuring very tiny signals. So it's around microvolt of the signal. It means we need an amplification. Okay. And also this is one of design, although later on I'm going to introduce one slide and just another way to design an EEG as well. One of the simpler way, we need amplifier, because tiny signal, we need amplified in a certain signal that we can use the chip, the microcontroller control. So it means we have to amplify into the level of the microcontroller, okay? Around that TTL level, if we're talking about the electronic. And after that, we need a filter, okay? Very simple design, we don't need sophisticated filter. We can use a filter later on in a computer, called DSP, digital signal processing. But if you want to make a good quality EEG, we can introduce a good quality signal filter as well. And if you search around, research EEG, that's pretty high quality EEG, even up to 50,000 Australian dollar, or around that money, we can buy good quality. But we can actually design that EEG in a much more cheaper. If we electronic people, we can design ourselves the EEG. And the last one, we need to convert that analog signal into a digital, okay, through the ADC chip. Okay, most of the embedded system or microcontroller, if we're talking about the electronic, they have a certain ADC. But a second design of the EEG, I actually play around with the higher bit of the ADC, which I'll introduce that one later on. And this is one of the EEG that I developed a few years back using what we call amplification. So this is one of the designs. So we need a different amplification. And also the embedded system. So I use the wireless because Now these days wireless make it easier and also safe as well. So we don't want to have the because if you use USB, then it means that there will be electrical safety concern as well. So we use a wireless, is pretty safe, and we use a battery power there as well. And this is the prototype of the first version of the EEG. And you can see that's so this one actually the wireless embedded system, and there's a different amplification in-amp or chip that been used as well. You can see there's a potentiometer if we're talking about the electronic that can change the gain of the system, and this is the specification of that particular design. So the one that we concentrate is, so this is 2-channel. Okay, the sampling rate. So normally in EEG we need to concentrate on the sampling rate. So the ADC bit is a 12-bit only. So we're using the microcontroller ADC bit, and the common mode ratio is important. So we need to be above the 80 dB, and this is tested above that 80 dB. This means good enough. If lower than 80 dB, it means we can just pick up a lot of noise, and the noise pretty tiny. That's 3.5 microvolt. Okay, and again can be adjustable, and then battery power. This is the second version that I talk about, so I can't provide the schematic because I haven't published this one, but I'll give you some hints here. So we improved this one using the dry electrodes, and the idea here, so instead of using the instead of using a 12-bit, so I use a 34-bit. So you can imagine that. So this one, even without amplification, if we can use a 12-bit ADC, if you go to the formula, we can actually directly access to the low level of the EEG directly. So without any heavy amplification, we can just use a good quality ADC bit, and plus the other chip, the Bluetooth, we can use that one for the EEG as well. This is my other version of the EEG. Now we need to test it after we develop the EEG. So one of the easy way to test the EEG is through the eye closed and eye open. So when we close our eyes, most of the people can find the alpha wave. So alpha wave is between the 8 to 13 hertz. This is one of the alpha wave that we tested. You can see in terms of the amplitude is quite different than open, and also the frequency is quite different as well. So I tested the EEG that we developed to get an alpha wave. And now we're talking about the applications. So one of the application that using a stimulus, we call it a P300. And one of my capstone students, the final year project student, in fact this year, so I asked them to play around with P300. So P300, this is they use for communication. They run this one diagonal and also in a row as well. So in a column and row, they flash that one very quickly, rapidly. So the person needs to concentrate on the certain alphabet. So because we know the timing, the integers and row and columns, it means we know which one they concentrate. And after that, we just check on the EEG signal. So this one, instead of the P300, means that peak after 300 is, in fact, actually is around 300 up to 700 milliseconds, we can pick it up a P300 signal. So it means that we can use this one as well for the communication. If you concentrate, we know exactly the person is concentrating on which letter, and we use that one for communication, or what we call a speller machine. That's how the BCI community use this one for one of the applications. Okay, and we don't need heavy signal processing. It's a temporal domain. It's concentrated on a time. It's not even a frequency. So here is actually the EEG signal in a time. So it means that we don't even need AI. So because the features is quite clear there. Okay. The second application of EEG-based BCI is what we call a steady state evoked potential. It means we concentrate on this one is LED. I use a black LED. If we flash on a different frequency, we can pick it up as well. Okay, and when my cursor is not there, so you can see here, it's different frequency, we can pick it up. And here we need to use frequency wise. So instead of time domain, we have to convert the frequency because that's the features. And the features is quite clear. It means that we don't need to use AI in this purpose because the features clear. We just need convert that one into a frequency. We can use a Fourier transform. We're talking about signal processing, and we can detect this as a BCI. And in fact, one of my system I tested and I published this one as well. This one for the wheelchair control as well. So I developed, this 3 LED flash it in a different frequency. So it means if the person concentrates on particular frequency, particular LED, they can use for different direction of the wheelchair control. So why not? We can use that one, and pretty precise as well. So this is the whole circuit because I use this one for the wheelchair control. So this is the embedded wheelchair control as well, and also there was EEG and the stimulus as well is there. And this have been published. You can search my publication, and I use this one for the wireless EEG that I developed it and test on the different stimulus. So this is the Fourier transform, the fast Fourier transform that we converted from the EEG that we recorded. You can see on a different frequency, 6 Hz, 13 Hz, and 16 Hz, and we find that stimulus, and we can use that one directly to control the wheelchair. It means the features quite clear. We don't need to use AI in this purpose. Okay. Now this is and also for the purpose of the publication, we test that one as well for the SSVP BCI with people with disability with the spinal cord injury actually. So I tested the SSVP, the stimulus there as well. As you can see for them, and it's quite accurate because we know the features quite clear, and the person just need to control that particular 3 LEDs there. Okay. And the last one here, I think we still have time there. So we introduce another one, what we call mental task BCI. And we use that one for the wheelchair control as well. And as I mentioned earlier, it's quite important people having a particular condition, what they call a lock-in mode. So we can tap into the brain signal. We can use that for the wheelchair control. But for the mental task, it's not that easy because the features is not clear. So we can't see like the P300. We know in terms of temporal, we can see very clear EEG features. SSVP, we know we convert it to the frequency. We can see the clear features. We don't need AI, but mental task is quite difficult. All we can see is non-stationary and non-linear. We can't see the features. We convert, become a frequency. We can't see the features as well. Motor imagery BCI is different. Motor imagery BCI, we can see the features. Even we don't need heavy BCI there because they concentrate on the mu rhythm alpha range, 8 to 13 Hz. But mental task is quite difficult. I can't see any features if we convert it to frequency. That's why we need an AI here. Okay, in my research, I published a few papers on using AI combined with mental task BCI as well. So you can see this is the general block diagram of mental task BCI. So this is the EEG measurement. We need to clean the signal through the pre-processing. We need a features extraction, and also we need the AI. So we need the data. We train the AI. We let the computer to recognize the features, and after that we use that one with the real-time AI-based BCI. We use that one to control the wheelchair. That's the idea. So for this research, I did collect data myself with a healthy participant, also with spinal cord injury as well. You can see it's quite a measure using actually I think this is a clinical EEG. So because I need to find the AI first before I put it into the EEG that I developed it. So this is the research. So get the ethical approval for this research as well. And you can see this is the EEG measurements. You can't see any features in terms of temporal domain, also with the with a frequency as well. And this is the mental task. So it's a mental non-motor imagery. So for example, a letter composing. So we just imagine compose the letter in your head. Mental arithmetic calculations. So we imagine a calculation around the head. And also the imagery rubric cube lowering, and also the additional eye close as well, because we want to test the algorithm. We can use this one to associate for the different wheelchair control. So control left, right, forward, and etc. And for this particular research, I actually introduce another feature extraction, because we can't see pretty clear in terms of frequency. Also the time we can't see as well, but I combine time and frequency domain. One of the methods I search around that we can use the Hilbert-Quant transform, okay, and it's actually can combine what we call an instantaneous frequency and time domain as well. It's quite interesting. That's why I applied to the EEG, and after that, that's for the purpose of the wheelchair control as well. And I did in terms of the publication, we compare with different methods that have been used in the EEG. So FFT and also wavelet is another time domain, a time and frequency domain as well. We can use for the comparison. Okay, that's the method of the Hilbert-Quant. You can check in their publication as well. They use for different publication. So Hilbert-Quant, I think the Quant actually is working with the NASA. They're using to analyze different data. Maybe it's NASA data and also different application as well. So this is the method of the Hilbert-Quant. So you can see they have to construct different envelope, and after that we need to find a local optima, and until it's become a monotonic signal. So it means they have to do iteration until the signal become monotonous to construct the signal. So we need to test that one for the Hilbert-Quant's spectrum for the EEG. So this is the EEG that I collected, and we know that alpha wave during the eye close is there. It's pretty good. And also is one of the publication, we use the AI, and also we optimize the AI as well. So AI is like a black box. It's basically we just need to find a formula. We let the computer to find a formula with the data that we supply. That's the idea of the AI. So one of the method called artificial neural network. That's the base. And in artificial neural network, there's a lot of optimization we need to use. And at that time, we introduce what we call a fuzzy particle swarm with a cross-mutated operation. This is part of the particle swarm optimization as well. We improve the optimization of the machine learning. That's why we can publish this journal paper for the purpose of the mental task BCI. So this is the features, the Hilbert-Quant. And I don't want to go that detail about the AI that we use. You can read into the publication as well. And let's go straight with the testing. So this one we test with the eye close system, and between the healthy and between the people with disability, the tetraplegic spinal cord injury. All of them, they can use the eye close as well, and the accuracy is maybe almost above 80% for people with disability, but healthy people almost 100% there. It's quite good. So in terms of the mental tasks, the 3 mental tasks that using the AI that we propose, you can see it's up to around 80% as well. Okay, and on the top there. And also if we increase the time interval, even up to 85% we can use as well. The time interval means how fast we want to classify the EEG for the purpose of the wheelchair control. So we can use 1 second, 2 seconds, up to 10 seconds, but for the purpose of journal, we find that 7 seconds is the optimum classification. This is at the end of the comparison, the one that we propose. And at the end for the wheelchair control, that we need to use less channel, and we test it with the 2 channel. I think the last one here, there's another video I can show as well, and how we control. Actually, it's using the 2 channel, using the Hilbert-Huang transform. It's mental task, and also with the AI as well to control the wheelchair. I do have actually I have another video that using the the stimulus, but I didn't show it here. But this is using the mental task. The SSBP is quite easier. We don't need to use AI, but mental task is quite difficult. We need to use AI, and I make it very slow here. I think it's around 2-second time window, but I move very slow the wheelchair. But I just use the 2-channel EEG for this control. All right, I think I'll just stop it here, and I think that's it for the presentation. And this is so far I have a few research PhD student. It's not only for the BCI, and also for different application for the research that can use for one of the student working on the rehabilitation as well, using different model, not only EEG. One of the student that flying research with the EEG for aviation. I think it's one of them, and also there's other research as well that doing different research. I think that's it. Thank you.
Yeah, thank you very much, Dr. Rifai Chai. So, ladies and gentlemen, that's all. Dr. Rifai already gave his very interesting presentation, I think, in the BCI application based on EEG signal method. So, we can see that Dr. Rifai already used some research product based on the EEG method using PCI for wheelchair controlling, right, Dr. Rifai? Maybe is there any question from the participant? You can ask directly to Dr. Rifai Chai, or you can type your question on the chat box. So I will read your question to the Dr. Rifai. Okay. Is there any question?
Excuse me, I have
Yes, you can ask directly. Okay, yes. Okay, Abdul Fatah.
Yes, excuse me, Dr. Rifai. I have a question. When collecting data for mental tasks, how to answer research participant doing the right job?
Can you repeat that one again?
When we collecting the data for mental tasks, PCI, how to answer research participant doing the right job?
Okay, to validate this. So in probably I didn't show it here. Let me see. So basically, in order to do that one, we need a protocol. That's why normally in experiment we have a set up protocol. So in a protocol, I actually use video as well before the participant using the perform the mental task. So the protocol is so we have to make sure we give a right command. So probably I give the command. Maybe we have to instruct them when they have to start the mental task. So there's a start and stop. But even before that one, I show the video. So I have 3 different video. Imagine a letter composing, for example, they're showing some video how to imagine as well. A clear instruction, and after when we action start, then they have to perform that one. I think I'll collect around 10-second data, but even that I don't use the 10-second data. I think the first 3 to 5 seconds I just chop it up, and then use the last hour to make sure they're doing a mental task imagination. Hopefully they're answering that question. But it means we have to use a proper protocol in that sense. I collect a lot of data. Some of them actually not easy to perform. Probably they don't concentrate, but because they mentioned as well during the data collection they can't concentrate. It means that I discard that data. So I just need to make sure we have to make sure that data that we collect is using the right protocol, and they perform on that particular mental task. Okay.
Yes, thank you. I have another question. When in mental task again, how to differentiate we acquisition EEG signal or noise.
Yep.
Oh,
Yep. I think it's about the noise system, because as I mentioned, we use the AI, and for other tasks, also the one of the EEG EEG signal, they have quite heavy with the eye blink noise. We're talking about the movement noise. And for the mental task, actually, I'm concentrating on the back of the head here. So probably I didn't talk about that one. So for EEG, the noise is quite affecting a lot through the movement and also the eye blink. As that's the purpose, I use the measurement for mental task is on the back of the eyes. If you see the two channel here, it's actually a concentrate on the occipital and around the parietal. So occipital is around the back, also the parietal as well, or even central. I don't use the channel around here because there's a lot of artifact or noises as well. That's the first thing. And also in terms of the spectrum, I don't use a lot in a lower spectrum because the movement is tend to have the in that area of the lower spectrum. For example, the delta, the theta. So this kind of that one of the spectrum of the EEG. I use a higher spectrum as well to avoid that movement noise as well. Now, if we're talking about the AI, and we collect the mental task signal, and the other signal that we can use, the AI can help to screen out as well. So AI sometimes is very helpful as well to just concentrate on, because the AI that we use is supervised learning. We provide the signal around that mental task as well, but other signal non-EEG, they treat that one as a noise because we don't provide that data to the classification, to the training. Even they don't recognize if the signal is not around the EEG, they will discard it as a noise. So it's not part of the classification. And I found that one is good as well. Be introduced using the AI. Hopefully that answering your question.
Okay, Abdul Fatah, are you satisfied with the good answer?
Yes, I have.
Do you
obtained
have
the answer.
any? Do you have more questions, Abdul Fatah?
Maybe one more time.
Okay.
How can we reduce the channel in EEG?
How we can reduce the channel? That's the one that the research that I provided. We have to provide an optimum channel. So to reduce the channel, we have to check with less channel is provide an optimum classification. That's one way to reduce channel. As another way is actually in a research. One of my students using different technique, but we have to make sure we provide an optimum result. There's another way we can reduce the channel through different different signal processing as well. There have been actually it's a research topic, and one of my students actually aiming for that particular area as well.
Thank you, sir.
Is it enough, Abdul Fatah?
Yes. Thank you.
Yeah,
Thank you.
thank you very much, Abdul Fatah. It seems that you interesting in this research, Abdul Fatah. Maybe you can send an email to Dr. Rifai to discuss more about your
Sure.
patient. Yes, in this research, maybe you want to develop a PCI application based on EEG method, maybe for medical rehabilitation or wheelchair controlling, maybe. Abdul Fatah, you can contact, so do not hesitate to contact Dr. Rifai. So from other students, maybe I would like to greet our participants today. Dr. Rifai is not only consist of Airlangga University students, but
Okay.
also
Yep.
the outside of our university. So
All right.
this
Yep.
is yeah. I have a look that there are some colleagues from biomedical engineering and physics study program in the physics department. Yeah, there are Pak Frankie and then Budia. Hello, Pak Patriama. Maybe is there any question from you to Dr. Rifai? Maybe to encourage your research. Yeah.
Yes, hello.
Yes, I know Mr. Khalid. Where are you
Yeah,
from, Mr. Khalid?
I am
Are
from
you
Yemen. Yeah, I am from
are
Yemen.
you master student?
Yes, I am master student.
Oh, okay, yeah. Okay,
Yes.
please, you can question.
Yes, I asked the professor about the side effects of the safety, and is there any side effect to comes with the long dealing with these signals to the patient? Also, are these signals that affect for the brain focus signal? Make an concentrating to the patient to make and concentrate to the signals. Thank you.
Yep. Thank you. I think Khalid, my pleasure to have you in here as well. I think the question is about the side effect. Because the one that I use at the moment is EEG. I think EEG is non-invasive. It's quite safe in terms of side effect. But we're talking about the invasive BCI. Maybe this need further study because there's implant as well, and of course as well for the long term. I'm not sure for the invasive. It's not that easy. It means that they have sometimes I believe that invasive BCI they have to replace that electrode in a few times as well. It means that they need to have the open surgery for quite some time as well. At the moment, I believe in the research for the invasive BCI, they concentrate on the particular patient like epileptic patient because they need to use they have to put the electrodes the micro electrode for them for the different purpose. That's why at the same time they're doing the research on the BCI. But you can see the company for the invasive BCI like Neuralink, they start to invest more money to go different area of the research. But most of my research at the moment using the non-invasive, they've been used in the hospital. So I believe it's quite safe. But although we can use for the particular research work, people maybe student can do some sort of a study or research and what sort of long-term effect for using the EEG for a particular BCI purpose. Hopefully that answering your question, Khalid.
Yeah, thank you so much. Thank you.
Yep.
Yeah, there is a question maybe from Pak Frankie first. I'm sorry, Bu Nurul, maybe later I read your question. Maybe Pak Frankie want to ask a question to Dr. Rifai. Please, Pak Frankie, you can deliver your question directly. Hello, Pak Frankie. Oh, yeah, maybe Pak Frankie have some problem with this network connection. So I will read the Bu Nurul Fitria question. Thank you, Dr. Rifai. It is a very interesting topic. In fact, I'm not an expert in EEG, but I read some references about it. If I would like to ask a question, different types of application require diverse AI approaches to maximize the success of the BCI. How did you train the user to learn and adapt their brain patterns toward a desired state? For example, in neurorehabilitation, where we want to change the brain to induce some behavioral change as a consequence. Yes, this is the question from Bu Nurul Fitria, Dr. Rifai.
Yep.
Maybe you can answer.
Thank you, Boris. Thank you for Nurul. I read that question here. I think about the BCI. Okay, as I mentioned in our presentation, there's I think I'll introduce three different EEG-based BCI. One of them is called P300 BCI. That one we don't need to use AI, is because we know the features is clearly is positive after 300 around 300 to 700 milliseconds in terms of temporal. We don't need to use AI. We just see the temporal. We just see directly the temporal signal of the EEG. We can detect that one easily without any training for the P300. The same thing with SSVP BCI is a steady state evoke potential. The one that I use, I have the LED, that 3 LEDs blinking on the different frequency rate. Okay, so the features is a frequency wise. So when we record the EEG, we convert that one to the frequency. We can use Fourier transform, or normally they call it power spectral density. It's Fourier transform as well. It's a frequency wise. we can see the features, each frequency on that particular stimulus. So I mean, we don't need to use AI. And we don't need to use a training. We can directly person concentrate. We tap into the brain signal. So because the stimulus used in the eye is normally around the occipital signal, should be very clear, because we know when we see the eyes, so in terms of the clinical, on the back of the head, on the occipital signal, we can pick that signal. So for the P300 and the SSPP, we just need less channel, even one channel is enough. We can pick up directly that signal. But for the mental task, is we can't see the signal. We need an AI. We don't need a lot of time for the training, as the person just need to concentrate on that particular mental task. The easy one is composing a letter, or even most of them pretty much straightforward. They just compose a letter in the brain, and also they just need to do a calculation. The calculation is not about right or wrong. It's just to keep performing that calculation in the head, and also the imaging rubric loading. And we let the AI to detect that one. I mean, the training is on the machine, it's not on the human. That's a different area. So the machine learning training is only once we run it. It's only like when we in a factory, but on the product, it's real-time testing. Use whatever machine learning that we train already. So it means that we don't need to use training anymore. Although this thing can be adapted, okay, that's in terms of it's part of the research as well. It's still in a research question. It means that how we can adapt for the new user, or the issue of the variability of the EEG measurement is a research question. But at the beginning, we don't need to use a particular heavy training if we want to concentrate on one particular subject. But if we want to make a journal, probably we need to adopt that things. So it means that we can introduce another little bit sample, maybe can use for the calibration. This is one way to adapt, but there's a different way called adaptive training, or real-time training, or even different way to improve the usability of different or new users. Hopefully that answering the question.
Thank you so much, Dr. Rifai. Thank you so much, Bu Riris.
Yeah,
This
thank
is very
you.
clear
Welcome,
explanation.
Bu Nurul. Yeah. Thank you, Bu Nurul. Okay, maybe 2 more questions. Yeah, Pak Frankie, are you ready to deliver your question, Pak Frankie? Because you already raised your hand. Hello, Pak Frankie. Okay, still trouble. Okay, yeah, there is a question from Miss Adiratna Ciptaningrum. Thank you, Dr. Rifai. I want to ask two methods of signal recording and processing, for example, filtering, method of classification, influence the effectiveness of BCI control. Yeah.
Thank you for the question from Adi Ratna. I think because as I mentioned about the block diagrams, each of the component in a block diagram is influence the effectiveness of the BCI. That's why I published a paper just talk about the features extraction itself. Okay, but even that one, when the measurement itself, we need for the real-time BCI. We talk about the real-time BCI control. We need a dry electrode. We can't use a gel-based BCI because it's not effective, isn't it? People have to use a gel. They need a dry electrode as well. And also, in terms of the pre-processing or the filtering, even in my research, I haven't tackled that area yet. But in fact, for the real-time BCI, we need probably introduce online artifact removal. But some other research you can search around. There's a chip that using independent component analysis chip that you can use that one. We can combine with a BCI to remove the artifact in real time. And my research concentrate on the features extraction. So features extraction component is pretty important. That's why one of my publication, which in fact a journal paper, high quality journal, I think it's a Q1 journal, I published using the one that I mentioned, Hilbert Wang transform that concentrate on that features extraction. Then also have the one publication for the AI as well, using different type of the AI. So all of this component actually is contributing to make an effective PCI control. In fact, for the safety purpose, wheelchair control, I'm talking about the wheelchair control. Maybe for other application, or maybe a speller machine, maybe much more easier for communication. But wheelchair control, because it means we have to move the wheelchair along as well. I mean, there will be other things that will be involved, and we can use sensor as well. So in my wheelchair, if you see the wheelchair, we do have different sensor. We have the 360 camera, we have the laser camera, we use ultrasonic. We can combine this thing to make it more safe in terms of the wheelchair control. Okay, hopefully that answering the question.
Okay, is it enough, Miss Adidatna? Yeah, I think it is enough, Dr. Rifai. So maybe Pak Frankie still have having network problem, Dr. Rifai. I think okay. One more question. Is it okay for you, Dr. Rifai?
Sure, my pleasure. Also, you can send me email as well if anyone want to contact me. You can ask me through the email if we haven't finished the question to answer the question.
Okay, yeah. Maybe this is the last question for you from Helsani Amalia. Good morning, Dr. Rifai. I have a question about the topic we have already discussed. My question is, what is the most features that you use for analysis EEG signal, and how we can choose features of EEG signals for the application of wheelchair control? Okay, thank you, Dr. Rifai.
All right, thank you for the question from Sunny. I think I mentioned here as well, we can use different EEG-based PCI, the one that I introduced. We can use P300 for the wheelchair control. You know, the person just concentrate on the flashing metrics or different way. I think I have one capstone student, finally a student that working on using the sound signal rather than visual stimulus as well. You can use the sound as a stimulus to provide wheelchair control. So we can use that one, and we can use the motor imagery EEG-based PCI for the wheelchair control. So it means that we just imagine left hand, right hand, head movement that associate to different wheelchair control. And the one that I mentioned in my research, I use mental tasks, different mental tasks. We can use that one to associate for different features, different wheelchair control. The features is along with the methods, like P300 is a positive peak after 300 or around 300 to 700 milliseconds. SSVP, it means the features is the frequency on a certain frequency and needs stimulus. Motor imagery, the features is ERD and ERS, the one that I mentioned, is a mu rhythm, 8 to 13 hertz. So if you see the research on the motor imagery, their synchronization, it means that mu rhythm is synchronized is lower, synchronized is higher. So it's up and down of the thing you can use for the wheelchair control as well. Mental tasks, the features is I use the different method. So you can use the Fourier transform. One of my publications, I combine time and frequency domain. I'm use the Hilbert-Baum transform as the features, but I let the AI to train the features because I don't know even the features inside. We let the AI to recognize the features themselves. Hopefully that answering the questions.
Yeah. Okay. Is it enough, Miss Elsa? I think it's enough, Dr. Rifai. I think it's time is up for our first session, all participants. So if you have more question or discussion to Dr. Rifai, we can send Dr. Rifai email address. So you can make more discussion freely to Dr. Rifai Chai. So okay, before we end our first session, Dr. Rifai, may we have take a picture together, Dr. Rifai, as usual.
Sure.
Yes. Yeah. So my student will take our picture. So please turning on your camera, participant. Yeah, we can see your smiley face. Yeah, okay. Helsa, are you ready to take a picture? Yeah, okay. We have only two slides. Okay, first slide.
Ready.
Yeah, okay. First slide is okay, done. And then second slide.
Okay, first slide. 1, 2, 3. Okay, next slide, ma'am.
Yeah, next slide. Okay. Okay, done, Elsa. Okay,
Done,
done.
ma'am.
Yeah, thank you very much, Elsa.
Finish.
Yeah, so we would like to say many
My
thanks,
pleasure.
Dr. Rifai.
My
Yeah,
pleasure, Ibu Riris.
yeah. Thank you very much
Yeah.
for your attending and nice sharing for us. We hope that we can encourage our knowledge and make maybe further collaboration with you, Dr. Rifai Chan.
Thank you, Boris. Thank you everyone as well for the participation. I'm happy to answer email offline. You can send me email as well.
Okay, yeah, okay. Thank you very much, Dr. Rifai. See you on the next occasion.
See you again.
Yeah, okay, bye-bye. Yeah, okay, participant, we are coming into the second session with our second keynote speaker, Mrs. Osmalina Rahma, SP, M.Si. So before we listen to Mrs. Osmalina presentation, I would like to share her curriculum vitae. Okay. Yeah. Mrs. Osmalina Rahma, STMSE, he got his Bachelor of Biomedical Engineering from Universitas Airlangga in 2013. And then he got her Master of Science in Biomedical Engineering from Universitas Indonesia, UI Jakarta, Indonesia, with the cum laude appreciation. Yeah, it's an excellent achievement, I think, Mrs. Osmalina. Yeah, Mrs. Osmalina is a very excellent young researcher and lecturer in our university. He already got so many grants here from our internal funding, and then from the Ministry of Research and Technology, Indonesia. And then she also have a excellent publication in the high reputational journal, I think, Osma. Yeah, okay. Mrs. Osmalina will share her presentation today about the EEG application. Yeah, in stroke, in stroke rehabilitation, right?
Yeah, thank you, Dr. Iris.
Yeah, okay. Without further ado, the time and screen are yours, Usman.
Thank you so much, Dr. Iris, for the explanation. Maybe I will set the presentation first. Okay. Okay, thank you for the opportunity. Good morning, ladies and gentlemen. Today I would like to share my previous research that still need a lot of improvement, and also maybe we need to discuss later. I also usually discuss with Dr. Rifai about the EEG, and I need to learn more about EEG from him. And today I will talk about the EEG as a supporting tool for acute ischemic stroke identification. As we know that brain is really powerful part in a human body, because brain is the center of the solar cell in our body, and all activity are monitored through the brain. This could also lead the fact that we could also detecting neurological disease by monitoring brain. However, observing the living brain is really challenging. And how we could observe the living brain without harming the owner? Actually, there are several methods here, but today I will focus on EEG. And EEG is measure the electrical impulse from the cortex only, and the electrodes placed on the surface of the skull and it provides information about the location and frequency of activity. And the other method, we could also use the imaging, such as functional magnetic resonance imaging or fMRI, or maybe CT scan. It could measure blood vessel, blood flow to outer and inner region in the brain, and it also provides information about location of the brain activity. And now we will be more focused on EEG rather than other method, since EEG become promising tools for detecting neurological disease. And this is also less risk of radiation, so it could continuously monitoring brain without any side effects, and also cheaper compared to the imaging methods such as CT scan or maybe the fMRI. Actually, EEG become the gold standard for diagnosing epilepsy because EEG is able to provide a definitive diagnosis of epilepsy when seizures are recorded. The frequency, the feature that determine the first decision brands are based on the morphology, or maybe we can see from the waveform shapes, and also the spatial distribution of the pattern. Usually the feature described by the frequency, spike, subwave, or maybe complex wave, and also amplitude, polarity, phase, rhythmicity, synchronicity, and symmetry, also reactivity and activation. Frequency itself is usually called as brain wave. It is delta, it's from 0 to 4 hertz, and then theta 4 to 8 hertz, and alpha is 8 to 13 hertz, and then beta is over than 13 hertz. And all brain waves represent the condition of brain. Normally people have alpha as a background frequency while EEG recording in a sleep stage or maybe in a eyes or closed eyes. But if the background frequency is not alpha, maybe delta, it also could lead to abnormality condition. So it can help to detect various diseases from the frequency domain. And the next one is spike or subwave. This is actually usually called as epileptiform spike or maybe epileptiform subwave because it usually becomes the sign of the seizure in the epilepsy. Spike is a sharply contoured waveform with a duration of 20 to 70 milliseconds, while the subwave has duration 70 to 200 milliseconds. When the pattern consists of 2 or more waves with a distinct form, such as spike, and then after it also following with a slow wave, it also referred as a complex wave. And the next one is amplitude. Amplitude usually refers the voltage of the waveform, and it is usually described as a term low. It is less than 20 microvolt, and then medium, it is from 20 to 50 microvolt, and then high is more than 50 microvolt, whereas less than 10 microvolt is abnormal at any age. So it also can predict or detect the abnormality from the amplitude. And then the next one is polarity. Polarity actually is referred to as a positive and negative. This is also correlated with the voltage or the electrode displacement, the channel to the reference or the channel compared to the other channel. This is usually useful for the spatial analytical analysis, and we can also find the reversal wave at the polarity. And then the next one is phase. Phases is actually according to the total amount of the changes in polarity direction. So if in one waveform they have more than one waveform or one phase, it will be called biphasic, and then if the waveform is contained to 3 turn up, it will be called as a triphasic. And then the next one is rhythmicity. Rhythmicity actually refers to the appearance of uninterrupted series of monochromic waveform, while the synchrony refers to stimulus bilateral left and right hemisphere, mirror image appearance of waveform, while the symmetry refers to left and right hemisphere amplitude, comparison of background activity or specific pattern. So symmetricity, maybe we can discuss later about the abnormality that we can see from the asymmetric of the left and right hemisphere. And about the reactivity, reactivity is referred to the degree of change that occur in EEG in response to exogenous and endogenous. For example, the alpha rhythm is defined in the part of body when there is a suppression in response to sustain of eye opening. This is usually determined as motion related potential that usually we can see a lot in the PCI, which is use this theory or motion related potential to define the exogenous and endogenous activity from this one. And while activation, this is referred to the appearance of particular pattern in response to stimulating procedure that is susceptible individual way to provoke an interactical epileptic form for abnormality or seizure. So usually we use the stimulation like light stimulation or photic stimulation. We use some light to which will blink in a various duration, and then also hyperventilation, which is take a deep breath and then release it fastly and repeatedly. This stimulation like hyperventilation and also photic stimulation are useful in triggering generalizing epileptic form patterns. So it can be useful for detecting the abnormality in EEG. Besides detecting the neural disease that correlated with epileptic form, EEG is also promising in detecting non-epileptic form disease such as acute ischemic stroke. This is based on the previous study that already done by Kenneth G. Jordan in 2004. This is state that EEG is a promising tool for brain function in real time, especially in intensive care unit. For detecting acute ischemic stroke, which show slow waves like delta and theta wave, as well as the cerebral flow reduced. And also studies by Putin and Tafi in 2004, which use a brain symmetry index method to measure asymmetric wave of right and left hemisphere using quantitative EEG. Here's the comparison of 3 patients with different age and different cerebral blood flow before and after clamping. Before clamping, the signal is still normal and contained with fast wave or alpha, but then during the clamping, the slow wave appear along the decrement of CBF or cerebral blood flow. CBF correlated with neural injury, which is we can see here, 35 to 70 is a normal condition, while less than that is showing the injury, or maybe less than 8, it considered as neural death. And from this figure, we can see that EEG is correlated with the CBF and also with the state of the brain. This also could that it is also could prove that EEG could measure the electrical activity of the brain, and so EEG was also a promising tool to detect stroke since it is not invasive and also cheap. EEG also correlated with changes in the cerebral blood flow level, which is decreased in a patient with brain injury or ischemic stroke. Actually, stroke was leading cause in Indonesia that needs special attention. The result of health research in 2013 were performed on people aged over 15 years and show the prevalence of stroke in Indonesia are 7% based on the health professional statement and 12% based on patient symptom. And the prevalence of stroke in group increased with age. The highest age is maybe in over 75 years old. And actually the stroke, the type of stroke is, there is 2 types of stroke. There is a due to the blockage, or we can call it as ischemic, and the other one is because of bleeding in the brain or rupture in the blood vessel, or we usually call it as a hemorrhagic. And about 85% of all stroke are ischemic, and almost 2/3 of stroke survivor leave hospital with the disability. So stroke could potentially lead to enormous physical social burden. and significant impact on health resource in the development national health system. So it is necessary to diagnose stroke, especially in early stage condition. This is the sample of the EEG signal that recorded from 68-year-old woman which have acute ischemic stroke on the left hemisphere. And this EEG recorded during the sleep stage. You can see here there is an asymmetrical wave that show with the arrows and also the label here. The square wave is showing the asymmetrical wave from left hemisphere, and then this one is the right hemisphere. There is a asymmetrical wave from the frequency and also the appearance of the slow wave here. The slow waves means the theta frequency and also theta frequency. This phenomena also can be assigned to detect the acute ischemic stroke on the EEG signal. And in this study, we try to collect the data and collaborating with the National Brain Center Hospital, Jakarta, and also I collaborated with Universitas Indonesia as well. And here we try to get the data from normal patient and also acute ischemic stroke patient. And here we also confirm the acute ischemic stroke location using the CT scan. And all the data were recorded with the format European data format. And then we use signal processing as well as such as feature extraction and classification. The recording was done for almost 30 minutes with the 32 channel. And the procedure as well, we use the standard operation that usually used by the physician in EEG recording. The electrode were positioned to the international 1020 system configuration. So the total is 32 channel in that already represent all the area of the brain. And to make sure that this data only affected by the acute ischemic stroke, not hemorrhagic or not chronic stroke or maybe the other neurological disease, we need to set the inclusion criteria. This is also quite challenging because not all patients realize the first onset that will not make it acute anymore. So it is already considered as chronic. So this is why we need to make sure that the patient already fulfill the criteria, which is the stroke onset is less than 72 hours after stroke. This is also very important to show the exact pattern before it is something again, or maybe become the infarct or lesion instead. The age also range for 40 to 60 years old. This is to prevent the higher age that also can followed by dementia during the stroke. So we need to make sure that they already sign the informed consent and also willing to do both CT scan and EEG examination. About the standard operation, here we use two devices. In a hospital, we have biologic with 256 hertz and then Natus device. This is a Celtec from Natus using 512 hertz frequency sampling. All total recording is 30 minutes, which is consists of 3 minutes closed eyes, 3 minutes open eyes, 3 minutes closed eyes again, and then with the stimulation of a light or photic stimulation using various frequency, and each frequency takes 15 seconds approximately, and then continue with the 3-minute hyperventilation, 1 minute post hyperventilation, and then close eyes for the rest of recording. And then after we get the EEG signal in European data format, we convert it into ASCII using the MATLAB, and then filtered it into 4 subwave band based on a frequency range like alpha, beta, delta, and theta, using power spectral density, which is a very common method for analyzing EEG signal. And we also compare data transformation method using the Fourier or FFT, and also the discrete wavelet transform or DVT. for comparison later. And in this study, we only use 18 channel rather than all 32 channel. This is to reduce the complexity, and because we want to measure the symmetrical level from left and right hemisphere, so we did not use the center channel. So this is only the 18 channel which has pair in the left and right hemisphere. Then we calculate the delta alpha ratio, delta theta alpha ratio, and then also brain symmetry index for picture extraction. These picture extraction are calculated based on power of each channel and also in each subband. And brain symmetry index itself is usually used to measure the degree of symmetry from left and right hemisphere. And the symmetry level is measured based on the average value differences of the power spectral density from left and right hemisphere. And its value is ranged from 0 to 1, which is 0 is perfect symmetry for all channel, and 1 is implies maximal asymmetry. So this is really not symmetrical at all from right and left hemisphere. And as a control, healthy subject has PSI value 0.042 plus minus 0.005. This is as a control or in a normal subject. And here's the comparison of healthy versus the acute ischemic stroke subject. And here we can see based on the result that acute ischemic stroke value tends to be higher than in the normal subject. Even though in a BSI, it's only slightly differences, but still acute ischemic stroke tend to be higher than in normal. And for classification, we use extreme learning machine, which is a single feed-forward neural network, which has a fast learning time and able to produce a high accuracy by using 23 data for training and 8 data for testing. We could get a high accuracy using the wavelet transform, using Dow-Beches-4 as a mother wavelet. After validating, using a 4-fold cross-validation, we could get the accuracy around 93% using the Dow-Beches-4 in the discrete wavelet transform. This is because Dow-Beches level 4 is orthogonal, which is close to the shape of the EEG signal, so that the Dow-Beches-4 has the smallest error value in the EEG signal processing compared to the other mother wavelet. Maybe here, this is the result of the software that I developed with the simple MATLAB. Here I try to training and testing all the feature using 50 hidden layer as a minimum value for getting the 100% training accuracy, and then also testing. So actually in here we can try to load another training and testing data, but here we just use the 30, at that time we just use 31 data for training and testing. And here's the sample for the acute ischemic stroke. We need to wait maybe around 2 minutes or 3 minutes until the signal open fully, and then we can see the EEG signal, and then we can identification the result. And for the normal, this is actually still need a lot of improvement because the data is only limited to the 31 patient. So we need to add more actually. And this is the example for the normal patient. We calculate the feature here, DAR, DTABR, and BSI. And then we can identify the result. And this is only 2 types of classification, which is normal and acute ischemic stroke. And then we also continue the studies to classify the acute ischemic stroke based on its severity level, because eventually EEG correlated with National Institute of Health Stroke Scale or NIHSS, which is the standard for measuring the level into mild, moderate, and severe based on doctor assessment from patient. We also add more data and group it into mild, moderate, and severe, and we get 30 data of normal patient, and then 8 for mild, and 16 of moderate acute ischemic stroke, and 5 of severe acute ischemic stroke. Actually, this is unproportional data because we have more data on moderate stroke rather than in mild and severe, because in severe and also mild, it's really hard to get the patient in this NIHSS, because in mild, maybe not all people aware with the onset, so it's not when they come to the hospital, it's not mild anymore and it's become moderate. But in the severe, it's really rare as well, because the severe is having the NIHSS over than 15, which is really the patient has already collapsed or maybe have the side effects of the brain. So we only achieve 5 severe patients in here. And the result, based on the BSI calculation, we can see that each channel is represent its area asymmetrically, but overall, the BSI tend to be higher in acute ischemic stroke type of severe rather than in moderate or mild. And the normal BSI have the lowest value in here. Then we also do the picture extraction like DAR, DTIBR, and also BSI. And with threefold cross-validation analysis, we use 36 data for training and 22 data for testing with the minimum hidden neuron 50. And we get the overall average value of the software is only 72%. This is actually still below the expectation because the data is disproportionate. We have more moderate data than mild and severe. So the system performance and stability were not done by variating the ratio of training or testing data, but by repeating the set data based on the k-fold cross-validation method. So it is essential that we need to have proportional data so we can get more stable accuracy performance. And also we need to look for another feature to get higher accuracy as well. And here is another finding about the epileptic form in acute ischemic stroke. Actually, eventually epileptic form wave are also found in some patients with acute ischemic stroke. So besides the asymmetrical wave from left and right, and also the appearance of slow wave, there is also found that some of acute ischemic stroke patients followed by epileptic form. Based on the clinic and sporadic EEG detection, seizure frequency in acute ischemic stroke range from 1.8 to 15%. So not all patients with acute ischemic stroke followed by epileptic form, but range to 15%, maybe they have followed by the epileptic form. And the seizure may occur early or maybe late or less than or more than 2 weeks after the onset. Nearly half of all seizure in acute ischemic stroke, it is 70 to 90% of initial stroke occurs in the first 24 hours. So this is the first 24 hours is less than the onset that we set in the inclusion criteria. So maybe some of patients have already followed by the epileptic form as well, beside the slow wave or asymmetrical wave. So we try to analyze it with complexity analysis using the fuzzy approximate entropy. This is try to analyze the changes of electroencephalography complexity in acute ischemic stroke. Hopefully this could be useful in differentiating and healthy subject and patient with stroke, or maybe helping to classifying the severity level of stroke to improve the stroke management. So basically complexity analysis have so much variant, but we only use the fuzzy approximate entropy to calculate the complexity. And the protocol itself, we try to generate all the patient from normal and acute ischemic stroke, but here we can do it on all patients. We only do to the several patients because not all patient has the same location of the infarct. So we try to prevent the bias. We just select the patient based on the same location, which is in the basal ganglia, and it's also have been confirmed by the CT scan that the location in the basal ganglia. And we try to cut the EEG only to 6 to 7 minutes during the hyperventilation and fatigue stimulation, because hyperventilation and fatigue stimulation is could be triggered to the epileptic form, and we want to try to measure or to analyze this epileptic form during the EEG recording to see whether the complexity changing or not. And the total of 18 electrodes were used to analyze the complexity change using the Papan method. And here's the result. And if we can see here, if we can see here, in our normal EEG waveform, they have Papan value around 1.09, and then slow wave appearance here, we can see it's more lower than the normal value. So when the slow wave or maybe theta wave or delta wave, it is held a lower value of Papan than the normal EEG, while the epileptic form activity had higher value of Papan than the normal pattern. And slow wave, which means that the complexity and regularity of EEG signal decreased during the appearance of slow wave, yet increased during the epileptic form activity occurred. So this is the detailed number from all channel. Yellow show that the value is higher than the normal subject, and green is lower than control subject or a normal subject. And we also compare the result with the expertise decision. We also try to look for the CT scan location of the infarct, and then we can see the result show that the patient with acute ischemic stroke tend to conduct the lower or higher Papan value compared to the healthy subject. So it can be lower or maybe higher. But if the Papan value is lower, it is because the presence of the slow wave on the EEG, while the higher Papan indicate the epileptic form during the recording. And the increment of the slow waves and the presence of epileptic form activity could be considered as a characteristic of stroke, even though its appearance is still uncertain. So not all patients have two kind of characteristic. Maybe another patient just have slow wave and the other one only epileptic form wave, or maybe they can have both of them. But however, complexity analysis of EEG could be useful in differentiating the health subject and patient with stroke, or maybe helping to classify the severity level of the stroke to improve stroke management. And this is as a sum up. There is a possible feature that can be useful for identifying acute ischemic stroke based on EEG. It could be more than this because now we have so fast development of signal analysis method. Maybe you can also try connectivity analysis to localize the infarct in EEG signal, because the connectivity analysis could help to get the temporal and spatial analysis. Beside this one is only frequency and time domain fragment analysis. And also the other possible classifier, you can use the conventional like peak propagation, LDA, SPM, or KNN, and also modified neural network like extreme learning machine, or maybe fuzzy combined with extreme learning machine, or maybe the newest one, deep learning using the CNN, or maybe the other algorithm for deep learning. And this is for the next challenge. I hope we could find the optimum procedure and the fastest duration on EEG recording to detect stroke, because previously we only used the standard operation that usually used in epilepsy. So we can hardly know that is it hyperventilation or maybe fatigue, is it necessary for stroke detection, or maybe we can reduce the time, not until 30 minutes, and maybe 10 minutes is enough for detect the stroke. We can still find out for the next research. And the second one is find the best feature to classify the severity level of stroke, because previously we only get 72%, so we need to increase the accuracy itself. So the we need to find the best feature, can be combining or maybe the other one. And the third one is real-time connectivity implementation. This is also essential for patient. So we don't have the offline data anymore, but we can implement it with the real-time connectivity implementation. So after they record the EEG, they will have the result right after the recording. And then the last, we want to identify which brain area or localization affected by stroke based on spatial analysis. This is also challenging because we can we have to analyze from the temporal and spatial analysis. So rather than we use the CT scan, we can optimize the EEG to find the exact location where the stroke implied. And this is also can help to manage stroke better after we can get the location affected. I think that's all that I can share today. Hopefully it brings more insight for all of us. Thank you very much. Maybe Dr. Iris, I return to you.
Yeah. Thank you very much, Mrs. Osmalina. It's a very nice and very interesting presentation from you. Mrs. Osmalina already told us about her recent result about the EEG application in acute ischemic stroke detection, right, Mrs. Osman?
Yes.
Yeah, we know that the stroke disease is still a very dangerous disease that can cause death suddenly, and we know that with no apparent symptoms or no apparent causes, so it can attack suddenly to the patient, and then can cause or can lead death fastly. So as similar with our first session participant, you can ask your question directly to Mrs. Osma, or you can type your question on the chat box. Okay, I will check the chat box. Okay. Yeah, this is from the question from Adiratna Ciptaningrum, Bu Osma. Yeah. Thank you, Mrs. Osmalina. Can I know what wavelet types you use to obtain? To obtain the value of DAR, DTABR, and BSI.
Yeah, thank you.
Yeah.
Thank you for the question, Mrs. Adiratna. Actually, I also try using the discrete wavelet transform. This is using the Dow Pages 4, and the level of the wavelet decomposition is based on the frequency sampling that the device provided. So if 256, then we can calculate each band from there. So we try to calculate the power spectral density from each subband like alpha, delta, theta, and beta. And then after we get the relative power ratio, then we just calculate the ratio from delta per alpha ratio there. And we also try to compare it using the Fourier transform, but it's come out that wavelet get the higher accuracy compared to the Fourier. I think I hope it's already answered the question.
Yeah, okay. Are you satisfied, Miss Adiratna Ciptaningrum? Maybe you want to give any feedback from Mrs. Osmalina answer?
Okay,
Yeah.
Mrs. Osmalina using Delbasis 4.
Yeah.
Have you tried another wavelet transfer of or another Delbasis, for example,
Yeah, I also try another.
or another wavelet
I
to
just
compare?
okay. I just use the dosages because previously the literature said that dosages is the similar with the EEG. So I only use the dosages, but with 4 point and 8 point. So I compare dosages level 4 and level 8.
Okay, thank you.
Thank you for your question, Diratna.
Yeah, thank you very much, Ms. Adiratna, for your question participation. So maybe the next question from Mrs. Nurul Fitria. Okay, thank you, Mrs. Osma. It's an interesting topic indeed. As what you have said, that the brain is the most powerful tool to get some information related to the patient condition corresponding with their EEG images. Is that possible if the EEG image of an acute ischemic stroke patient can be analyzed with its EEG result belongs to patient who has a mental health disorder?
Okay, thank you very much for the question, Mrs. Nurul. Actually, brain image is also popular in EEG or maybe QEEG, qualitative EEG. Yeah. Because with brain mapping, we can see the power relative ratio from each subband in the brain using the image. So there is also another method to get the brain mapping from EEG signal. And if we can see from the other disease, yeah, I think it is possible to see the EEG with the patient with mental health disorder. But I think several studies also done before to see the EEG like during the mental health condition or maybe the anxiety. We can see everything from the brain, right? So EEG signal is still have a possibility to do another mental disorder or maybe the neural disease, another neural disease. But maybe we still, it is still challenging because EEG is really complex signal. So we need to make sure that our signal is, or maybe our feature is adequate to differentiate all the disease. I hope it can answer the question, Ms. Nurul.
Okay, how about Ms. Nurul?
Thank you so much. Yeah, thank you so much, Ms. Osma. I think it's a very nice, interesting topics because if you know that the EEG is also a powerful ways to analyze and to know the patient condition, I think it will be very good if we can process it, analyze it, and in a very accurate ways. Thank you so much, Bu Riris. Thanks so much, Bu Osma.
Yeah, I think
Yeah, most
EEG can also, I think EEG can also detect the concentration from its subject. So it also can analyze the mental health disorder because some of patient with disorder or mental health disorder has a different kind of concentration, or maybe they are already lost focus, and it also can be combined with another sensor like maybe electrodermal activity, Mrs. Nurul. So maybe not only EEG, but we can have another supporting tools or a supporting sensor that can make the analysis more accurate as well.
Yeah, okay. Thank you very much, Mrs. Osmalina. So from the other participant, is there any question? to Mrs. Osmalina? Maybe from the students or the colleagues, maybe. You can, you can type your question on the chat box. Okay, I have a question, Mrs. Osmalina. So, according to you, how long we involve involved in this research, so in order to yield the end product of this tool. So I think this prototype is very useful for us, especially in the stroke detection, and then maybe Punuru already explained about the mental disorder maybe, and according to you, how long we can prepare this research to become the end product or prototype?
Yeah, thank you for the question, Dr. Iris. Actually, as for now, we are not, we still could not have developed the end project. We still done it until the prototype itself. The other team that led by Dr. Sastra also developed a prototype, which is usually embedded with the software that can classify the acute ischemic stroke, but still in a prototype. So actually we want to do the same with the hospital, like 32 channel. This is the minimal channel for diagnosing disease, but we only can get the 16 electrodes, because for the publication, the sensor itself has maximal 8 electrodes. So if we want to add more channel, we have to make it as double layer. And if we want to achieve until 32 or maybe 64, we have to do a triple layer or maybe 4 layer. And the manufacturer in Indonesia, there is still can do it. We have to send it to China, but it should be in a biggest amount. So we just only need 1 or 2. And this is also the limitation that we facing about the project. So we just stop until 16 electrodes, and I think still having a good accuracy if we add more data and add more analysis, like the severity level or the exact location. I think still conducting, and then I think then the time is depend on the team, and then now we have separated team as well, so the progress is slower than before when we are still together. I think that's the problem also that we are already facing in this research, Dr. Iris.
Yeah. Okay, thank you very much, Mrs. Osmalina. So the next question from the chat box from Kaulia Zalda. Thank you, Mrs. Osma, for the explanation of the topic. I want to ask about the result in the accuracy in using the Dobitsch's method. Why the level 4 have the higher accuracy compared to the level 8 Dobitsch's? Okay, thank you.
Okay, thank you, Coelia, from your question. Actually, in the wavelet as a mother wavelet, we have to try several mother wavelet to see whether the signal is suitable for our signal. The mother wavelet is suitable for our signal. The more it match, the more it can get the accuracy, the higher accuracy. And based on the literature that I've read from Tumari, the OBG's level 4 is closer shape, have closer shape to the EEG signal, so it can have more suitable with my EEG signal, and then it can get the small value, because actually it has comparison, like suitable, like our signal, and then we will compare to the mother wavelet as comparison. So if it have the exact correlation, then it will get higher accuracy. So basically in signal processing or then feature selection, we just need to try. So based on the literature that we read, we try it and then see what happened with our data, because sometimes in the reference it can get higher accuracy but not in our data. So basically we need to try and then we need to select the feature based on the performance, and then if the accuracy is still below the expectation, then we need to try another feature or another matter wavelet again. So basically we need to try by ourselves based on our references. I hope it can help solve the question, Kolia.
Yeah, how about you, Kolia? Are you satisfied with Mrs. Osma's answer?
Yes, thank you, Mrs. Osma, for the answer.
Thank you.
Yeah, okay. Thank you very much, Kolia. Okay, from the other participant, is there any question? Yeah. No question? Yeah, I think it's enough, Mrs. Osma. Yeah, yeah. I think everyone already interesting and attractive with our webinar today, with some result from Dr. Rifai and from Mrs. Osmalina. That is a wonderful research, I think, in EEG application. And we know that EEG is still open wide opportunities to develop in the medical signal research, because so many applications we can build from this EEG prototype or EEG signal, right, Osma?
Yeah, I think that's right.
Yeah,
Still
because
quite
a lot of
challenging.
information we can extract from our brain, yeah, to make some medical, maybe medical devices that is very useful for the all human being. Okay, I think it's enough, Bu Osman. Yeah, I think thank you very much. I would like to say many thanks to all of you, the participants, for attending our wonderful webinar today. We hope that our webinar today will be more beneficial for us to encourage our knowledge, especially in biomedical instrumentation. Okay, give a big round virtual applause for all the keynote speakers today and for the all participants. Thank you very much. And then we apologize if we made some mistake from our event today. Okay, see you everyone for the next question. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much.
Thank you very much.
Yeah.
Thank you so much, Bu Riris, Bu Osma,
Yeah,
and the
thank you, Bu
committee.
Nurul.
Welcome. See you.
See you.
Terima kasih Bu Osma, Bu Riris. Saya izin lah.
Yeah, thank you, Adi Ratna.